Thank you, everybody, for coming. It's my pleasure to present to you this morning at Grant. And the title of my talk is Bandaids, Safety Pins, or Get Out the Hammer, Emergency Medicine Patient Safety Solutions. And before I start, I just wanted to mention that I've had the opportunity the past few weeks to visit a few academic emergency departments across the country. And it really does engender a lot of pride in being from the University of Ottawa. Sometimes you don't realize how fortunate you are until you go to other places. I was asked to sit on a panel at the University of Calgary's Research Day to talk about how do you promote and cultivate a career outside of clinical medicine, in clinical medicine. And we were talking about some of the key things you need to look for in your environment, but one of the theme amongst all the members of the panel was you really have to have passion for what you do. And I'm really lucky that I found something I'm pretty passionate about, and that's patient safety. My plan for you guys today is to give you a state-of-the-art talk on patient safety and emergency medicine in this area, which really is exploding in emergency medicine research right now. By the end of this talk, you're going to be able to describe common emergency department patient safety problems, some proposed solutions, some evidence around effectiveness of these solutions, and some future direction safety research. What we're going to talk about first is about systems. So what is a system? How are patients harmed by the system? And how do we know which solutions will likely be effective at enhancing patient safety? Let's start with that. What's a system? Throw this to the back row. Anyone? Looking side to side. You guys know I'll pick on you if you don't volunteer. The questions get hard. Anyone? Treats? Okay, so Mike says it's an organized network of processes and tasks. I think that's pretty good. Yeah, essentially, a system is basically a series of parts and their interconnectedness that they're coming in for common purpose, right? It's not a complicated concept, really. You all know what a system is. But as healthcare providers, we don't often think about ourselves as being part of a system. We think about ourselves in terms of our work and what we do, in terms of our interactions with our patients and our direct peers, but not really how we interact with the whole system. And the WHO defines a healthcare system as a series of organizations and people who are really oriented around the common goal, either restoring or maintaining health. So if we take a bit of an ED-centric view here for a moment, right, the components are you have patients and their families, we have our emergency department, we have the hospital, we have the community, and the community includes healthcare providers, organizations, and we have government and industry. This is an example of a system. But what's interesting about systems is that, as this sort of diagram illustrates, there's layers, right? So if we took this layer here, the emergency department, what are the components of the system in our emergency department? What makes up our system? Healthcare workers, so there's people, right? So there's physicians, residents, nurses, respiratory therapists, clerks, patient care assistants, ECG techs. What else? People? Equipment, yes. So there's equipment. There's the tools that we use, right? So this is a picture of a recess bay. There's a lot of equipment and tools that we use. What else? The patients, right? The other important part of the people are the patients and the families. Flow in and out of the department, so how people get there, how people leave. Location, space, physical space, right? Where you are operating. So patient, people, environment, right? And within these components, patient includes their families, people include all the healthcare providers and the people who back them up, and the environment includes not just space and tools and equipment, but also the administrative environment, how your policies and structures are set up for your department as well. So how can a patient be harmed by the system? I mean, those of you who know me, I have this slide in almost every single presentation, right? What is an adverse event? And the reason we talk about what an adverse event is in safety is that the way we talk about adverse events in patient safety is different than how we talk about it in the rest of clinical medicine. If you read a drug trial, they talk about adverse events. What they're really talking about is adverse outcomes. Something bad happened to the patient. But in patient safety, what we're interested in are events that are unintended harm that happen to the patient, which is related to the care that was provided. So it's that related piece that's critically important. And it's rather than the underlying medical problem. So we know that patients who have bad disease have bad outcomes. Unfortunately, sometimes that's inevitable. But likewise, you can have a harmful outcome that's related to the care provided, which in some instances is not preventable, but in some instances it is. So another way of looking at it is harm to the patient can happen either from the underlying medical condition or due to an adverse event, which can be due to inherent risks in the investigations and treatments that we do. So these can be non-preventable sometimes. It can be due to system failures, and it can be due to issues with provider performance. But it can also be due to a combination of all of these. So what I'm going to ask you guys now is I'm going to ask you to do a compare and share. So I'm going to ask you to turn to your neighbor and take 2 minutes to think about what are the system contributors to adverse events in the emergency department. So I want you to come up with your neighbor. Yeah, shake hands, meet each other, say, hey, how are you? And I want you to take a couple minutes and say, okay, I want you to think of 2 system contributors to adverse events. So what are system problems that cause adverse outcomes to patients? Go. Are you sharing? Share? His parent is sharing. You guys have come up already? You're done? Okay, all right. Okay. All right, so now I'd like to find out what you guys all paired and shared about. So what I'm going to ask you to do is I'm going to have, from each of these big sections, I want to hear something from the back, the front, from each one. So start at the front. James, come up with anything? Okay.
So a system that forces us to use probability all the time. But the nature of that is that sometimes we will roll snake eyes and probability will do an adverse event.
Okay. So interesting. So a different way of looking at, in terms of the system, that we have to deal with probabilities. We have to deal also with the patients who come in. There's some cognitive biases that fall into that as well, which are really interesting. Top, Lisa, now you guys come up with anything? Joanna? Fantastic. So communication errors. So definitely system-based, right? Because again, we communicate with so many players in the emergency department, and as you rightly pointed out, communication can be in the written form, it can be in the verbal form, it can happen in team resuscitation, it can happen just on one-to-one interactions, so definitely communication issues come into play. At the back row, you guys come up with anything?
Availability of infrastructure, so a lot of what we deal with turns into like crowding issues, you see people offload, you have scavengers, present target actually make it difficult to interact with what's going on in your target.
Yeah, for sure. Crowding.
Overcrowding within the hospital.
Great. So yeah, crowding not just in the ED, but crowding in the whole institution, right? And how that trickles down and affects all of us. So that's a sort of more micro and macro system thinking. You guys, I got the research team here to back me up, which is really awesome. Did you guys come up with anything in your row? Yeah. So workload and fatigue, and that is really interesting too in terms of how we structure our system. We tend to think a lot of times that workload and fatigue are just the nature of the biz, right? So it's just part of the deal to how you do it. But you can structure a system to mitigate those factors. You can structure a system to actually reduce the impact of fatigued clinicians and overloaded physicians in terms of harming patients. Okay, how about the back row? Jeff, Tim, Ian, do you guys come up with anything?
Ian mentioned surge capacity and the decisions that are made that are logical in terms of deciding on resource access that decides whether you're going to have surge capacity. It's also a staffing issue.
Yes, surge capacity I think is something, to be honest, for a lot of times we thought in emergency medicine was kind of a figment. Like it wasn't really a reality for us. Like how can you really build surge capacity? We simply just can't because we have what we have. But we are learning now that there are actually some innovative and creative ways to build surge capacity, even when we are in a restricted resource environment. So that's becoming a hot area. Justin, Gary, Alicia?
Well, somebody stole our thunder when they talked about fatigue. I was going to say fatigue and shitty scheduling, and Gary hit me. Whenever you talk about this, I mean, I think you have to think of basic non-median quality assurance, structure, process, and outcome. The interplay of structure and process systems, how you use your structural elements, the interplay with each other is the answers to all this. So like offloading, what in our structure has led us to having no place to look after these patients, and staffing to deal with them, etc., structural things. And then how do we deal with them once our triage system isn't working?
Yeah, so really key concepts there in terms of structure, process, and how those influence outcome, right? And a good example in terms of offload. So I've chosen 5 to talk to you guys about today. The first is ED crowding. The second is interruptions. The third is information gaps. The fourth is transitions in care. Transitions in care, again, we tend to think about, and I am going to speak about handover in terms of shift change today, but you have to really, again, think broad in this. So transition in care includes from the pre-hospital setting to the emergency department, from the emergency department, within itself, so nurse to nurse shift handover, physician to physician shift handover, and then there's a handover from emergency department to consultants, emergency departments to the floor, emergency department to the community, right? So all of these are transitions in care that are relevant to what we do every day. And then team structure, we're also going to talk about. So interestingly, there is a survey that looked at 3,500 ED clinicians in the U.S., and they asked them pretty much similar, although more structured questions to what I just asked you, which are, what are the system contributors to adverse events? So what are the systems that are considered safety? And these were the 4 key things that came out of the survey. One was environment and space. The second was staffing. The third was inpatient coordination. And the fourth was transitions in care. So to give you some examples for environment and space, about 1/4 of respondents said that they didn't have enough space to manage the volume of patients that they had at least 25% of the time. And then about half of the respondents said they didn't have the space to accommodate the volume of patients at least 50% of the time. For staffing, it was noted that in terms of physician coverage, about 60% of respondents felt that they did not have adequate physician coverage to accommodate patient volume. And 75% of respondents felt that there was not adequate nursing coverage to manage patient volume in their EDs. In terms of inpatient coordination, they asked them some interesting targets. They said, how often in your ED, if a patient is critically ill, that you get a response from your service that they actually come into your ED within 30 minutes of making the call? And 30% of respondents said that happens most of the time. So in the majority of cases, that doesn't happen all the time. And likewise, they said, if your patient, let's say, is admitted to ICU, how often does that patient go up to ICU within an hour? And essentially 25% of respondents said that happens in our time. In terms of transitions in care, 75% of respondents felt that there was often missing information being communicated between physicians at handover. And 85% of respondents felt that there was often missing information between nurses in handover and of shift change. They also asked about, I'll get to a second, Sean, they also asked about whether or not there were issues around triage, medication, and access to equipment, and these were not endorsed as critical issues for safety. No, this is completely like, just tell us what you think about the issues of your ED and what you think the priority are in terms of safety. So there's definitely limitations to it, right? It's also only academic emergency departments where issues around crowding are more first and foremost, where there's perhaps issues to access to resources are more of issues, say, in rural emergency departments. And there's obviously a self-selection bias to people who answer these surveys, right? So you do have to take it with a grain of salt. But it is an interesting sort of data collecting exercise to ask people, what do you think are the critical system issues that contribute to patient safety? So for crowding. So many of you are familiar with, I think, Astrid Gutmann's article in BMJ in 2011, along with Mike Scholl from ISIS, which looked at 14.5 million ED visits in high-volume Ontario emergency departments. And they essentially looked at what is the risk of dying within 7 days if you have an increased ED length of stay. An increased ED length of stay was defined as more than 6 hours. And they found that there was an association between your risk of dying and being in the ED for more than 6 hours. And the odds ratio is there. Likewise, Stacey Ackroyd-Stolitz from Halifax did some work in a retrospective cohort study looking at if you're over the age of 65 and you're in the ED for more than 6 hours, what is your chance of having an adverse event when you get admitted up to the floor? And there was a positive association with that if you're older, the longer you're in the ED, the more likely you have an adverse event when you go up to the floor. So it suggests that, and this is the reason why this is so interesting, and it's like 2011 is the first time we've gotten this data, is that we've always thought that crowding was bad, but it was always hard to sort of demonstrate any associations with outcomes. Now, the limitations obviously are, like in large population studies, like the one from ISIS, you don't know why those patients died. You don't know if it was associated with the care, if it was associated, with specifically what happened in the ED. But the number of visits is so large that, if you're saying it's going to be due to severity, illness, and that kind of thing is less likely. And likewise with Stacey's study in the elderly, it was a retrospective study. There is certainly hindsight and outcome bias with that. But it is some of the first literature to suggest that crowding is harmful to patients. Interruptions. So Carrie Chisholm in the States is a really neat, it's called a time motion task, where you have some people just come and follow you around and just watch everything you do in terms of procedures. And they basically just observed emergency physicians in 3 academic emergency departments. And they just recorded every single time they got interrupted. And they defined an interruption and a break-in task as 2 different things. So an example of an interruption is, let's say I'm charting, and the clerk says to me, Dr. Calder, was that plastic surgery you wanted, Paige? And I said, yeah, that's right, it's plastic surgery, and I keep charting. That's an interruption. A break-in task is if I'm in assessing a patient and says, Dr. Calder to recess, and I leave the room, I go take care of the patient in recess, and then I have to go back into that room later on. So that would be a break-in task, right? So what they found was that there was a mean of 7 to 10 interruptions an hour and 7 break-in tasks an hour. And they worked it out that was about an interruption every 12 minutes. So does that matter? So if you get interrupted a lot, does that impact on your decision-making? Does that harm patients? And again, intuitively we would say, yes, that would make sense, but there's no data to support that as of yet. Jean and Monod did a really interesting study in 2010 where they actually took a little step further, and they said, okay, we're going to do the same thing. We're going to go and follow merge docs and track their interruptions. But after we observe an interruption, we're going to ask this patient afterwards, how satisfied are you with the care you received in the ED today? And the patient was blind in terms of the intent of the study, as were the physicians. And not surprisingly, you had an interruption in your care as a patient, your patient satisfaction was less. And particularly if it was a bedside interruption, right? Like all these other interruptions where patients don't were less impactful. But if it was that example of I'm assessing a patient, I get called to recess, I just left, is less satisfied. Again, is this related to outcome? We don't know. Information gaps. So Adam Quinn's son, Matthew Quinn, did a really nice paper looking at nursing home transfers. And the question was, this is like a daily frustration of ours, right? You get a patient from a nursing home, they come with documentation, and the documentation's incomplete. So what Matthew looked at was he looked at about 700 nursing home transfers. He said, for all these transfers, how often is there missing information? So 85% of the time, there's information missing. Okay, that sounds like a lot. Well, what kind of information was missing? Well, at least 50% of the time, advanced directives were missing. That's pretty important. About 30% of the time, there was missing information on baseline cognition. What is this patient baseline? How do we know the way they are now is different? And also about 30% of the time, vital signs in the nursing home were missing, as well as presenting complaint was missing about 15% of the time. So some of our nursing homes, you may have noticed, use a standardized form. So they use a form where it's like all the same for a series of them, and they're required to fill out these different sections. And so they looked at, okay, well, if you're using a standardized form, which is about 42% of the cases reviewed, are you less likely to have information gaps? And the answer was yes, you were less likely to have information gaps, so about 75% of the time, but still missing critical pieces of information. So again, the question is, does it matter? And again, intuitively, we would say yes. Does it lead to over-investigation? Does it lead to different therapies? Does it lead to sometimes sending a patient back because you don't know why they're here and maybe they needed further assessment? We don't really know, but the data suggests that the exposure of an elderly patient, for example, in the emergency department is potentially leads to adverse outcomes, and would enhancing that information and communication between the two make things better? The other limitation to the study was that they didn't look at oral communication. So if a nursing home actually called and said, oh, hey, we're sending this patient, but as they commented in the paper, that doesn't happen very often, so they thought that was going to be less impactful. So transitions in care. So I know Janet Newth presented a case at M&M Rounds, which I wasn't here last week, and touched on handover. There's been a lot of work looking at handover, and not just throughout the institution and different areas of the community, but also in the emergency department. And there's been a conceptual framework that's been created, sort of theoretical framework in terms of what are the key components and principles behind handover, what is it for. And there are so many mnemonics that have been created to help with communication that there's now a systematic literature review where they summarize all the mnemonics, and there's at least 30 in the literature. None of these have really been universally adopted. There's also a handover assessment tool which you can use to sort of assess how good you are performing handover, which is quite interesting. There was a study by Yi in Australia which actually did observe 700 handovers and tried to correlate it with patient outcome. So what they did was they observed the handovers, they looked for missing information, they surveyed the physicians after to say, what did you think about the quality of that handover, and then they followed what happened to the patients. And I think, not surprisingly, they found that there was no impact on outcome. However, they did find association between if there was missing information, the perception of quality likewise was not as high. And I don't know that we'll ever find out that handover actually adversely affects patients. You hear it said in the literature all the time. People say handover is bad, it's prone to error, it's prone to creating harm for patients. But to actually demonstrate that that harms patients is really challenging. There's a lot of confounders that come in there. So I don't know that we'll ever discover that. But it is a potential threat for patient safety. And finally, teams. So in terms of teams, we have a lot. Yeah, Janet.
So the only study that I know of that actually looked at following up questionnaires is the one that came out from Florida that looked at meeting sign out, and they actually had a pre and post meeting sign out mnemonic demonstrated decreased adverse events and more time spent at the bedside pre and post implementing sign out. That's where the whole ICAS mnemonic has come from, that group, and now they're doing this site looking at adverse events in patients exposed and bedside.
Cool. Yeah, we really need to see the results of that. And having sort of done some work, as you know, Alexis Haliga did her research project on this, and Krista Dakin's taking that on further. It's a very challenging area of study, and it is really hard to tease out whether or not any associations you find are truly due to relationship to handover or due to other issues with care. So trauma teams, so the introduction of trauma teams and ATLS. But interestingly, there's some literature. Georgiou did some videotape recordings. This is really hot right now, is actually videotaping trauma resuscitations and looking at team communication. And they did that in Scotland at a Level 1 Trauma Center, and they found errors in communication more than 50% of the time. Now, again, the next question is, does that error in communication translate to problem and outcome? But when you look at critical incidents, so when patients have died and you sit down and do a review, communication failure is the most common cited issue. And can you relate to this idea of communication problems in trauma resuscitation? Right? So this is an issue. But interestingly, I think sometimes we think it's like it's our center, and we know that that you can do it better. But it's actually a universal issue: is communication around trauma. And the answer is yes, we can do it better, and there are ways to do that, and we're going to talk about that. So the bottom line around these 5 system contributors is we still don't know what's most strongly associated with causing adverse events and outcomes, and we do need some more work, particularly around the impact of ED crowding, team communication, and transitions in care. But I'm going to shift now a little bit to talk about solutions. So I sent out a survey poll to some of my safety colleagues to ask them, what do you think are the most promising interventions for patient safety in emergency medicine? And the first answer I got was from Pat Crosscarry. So some of you know Pat Crosscarry. He's an emergency physician in Halifax. He's also a PhD in psychology, and he's written extensively on clinical decision-making in emergency medicine and cognitive biases. And Pat said, cognitive debiasing. Shocking, most promising patient safety intervention. But what Pat said, and that he said, clinical decision-making is so key to what we do in emergency medicine. We don't think about how we can actually improve the decisions we make and cognitive debiasing, then we're really not going to move ahead. So, and in large part, he is why we structured our M&M rounds model to include the cognitive issues when we discuss our M&M cases. The other response I got next was from Bob Weir. And Bob Weir is a emergency physician in Jacksonville, Florida. He's also a PhD in human factors engineering and resilient systems, and he's a leader in patient safety in the U.S. And what he said, which was interesting, was cleanable equipment, end-tidal CO2 monitors, and usability testing. Now, some of that might sound a bit kind of like, huh, or mumbo-jumbo, or what is he talking about? So I'll just explain that. So cleanable equipment. So there's this really neat project that was done in the London School of Design, where essentially they took all these design students and they said, we want you to redesign healthcare equipment so we can clean it better. So the one most impressive example was the blood pressure cuff. So the blood pressure cuff, as you all know, has Velcro on it. How easy is it to clean Velcro? Right? It's extremely difficult to clean Velcro. And Bob's point is, what is the point in telling us to wash our hands all the time and do better wash your hands if you're going to pick up a BP cuff that just touched 10,000 patients? So what they designed, which was really cool, was a magnetic BP cuff. No grooves. It has no cracks. It has no Velcro. It uses magnets. Still works. You put it on. You can wipe it clean. So the idea is that that will actually prevent hospital-acquired infection if you have cleanable equipment. And they didn't just do that. They took it beyond that to doing like, even, you know, the bedside, the table you bring up to the bedside. You ever notice how those tables have a whole bunch of grooves and cracks and all those kind of things? All of that really is a great place to keep bacteria and is really hard to clean. So they designed these smooth modular units, which are super easy to wipe down, which aren't going to hold bacteria. So kind of neat concept. And CO2 monitors, he said, you know, this has been used widely in anesthesia for a long time. It's been hot lately in the procedural sedation literature. And he says, you know, I think we need to bring it into emergency medicine. And he goes, I think it's going to help make patients safer in the emergency department. And then usability testing. Does anyone know what that is? Usability testing? Ring a bell, anybody? Rhea?
Things are designed so that you understand that
Right, so this is like what a lot of human factors engineers do, which is basically looking at the interface between the human being and the machine. So we know you can design a machine that will make it less likely for a human being to make an error when they use it. And 2 classic examples are the IV pump and the defibrillator. So there have been, there's basically this massive list of critical incidents and patients being harmed by IV pumps. Because IV pumps, if you look at the way some of them are designed, some of them are really tricky and complicated, sometimes unnecessarily so, and make it very easy for you to like program in the wrong dose, or it goes in too fast, or what have you. And there have been a lot of medication errors and harms to patients as a result of that, very well documented in literature. So there's a group out of Toronto in UHN, and that's what they do, is they basically say to the hospital, you want to buy a new IV pump? Let us test it for you, and we'll tell you how prone it is to human error. And they'll give it a grade. So if a hospital's looking to buy an IV pump, the next question should be, you know, for obviously cost consideration, but what's the usability testing grade? How likely is it to create errors amongst staff when they use the IV pump? And the next example is a defibrillator. So when I did my patient safety fellowship, we had this really cool exercise where they broke us into small groups and they said, we want you to design a defibrillator. I'm like, what are you talking about, design a defibrillator? And I said, what we want you to do We want you to take these components and tell us how to arrange them to reduce error. And the components were on-off switch, jewel selector, charge, shock. Pretty simple, 4 components. But arrange those on a diagram, on a panel, so you're going to reduce the chance of error. And it was really neat because we got to talk through, okay, well, what are each of the steps when you actually use a defibrillator? What do you need? And how would you actually, for example, should the on-off switch be a toggle switch? Should it be a push button? Should it be a circle? What color should it be? Should it be green? Should it be red? So all these really interesting conversations came out, and then we discussed the defibrillators on the market and also some of the critical instances that came out. So, for example, there are some defibrillators where it's actually confusing in terms of what is the on-off switch and what is the charge switch. And they had a few cases where someone was hitting charge and they actually hit the off button, and the defibrillator would just power down for 2 minutes before it'd be able to power up again. That's clearly a problem. So, again, UHN is doing this where they will evaluate a series of defibrillators and say, okay, this model is less likely to create human error versus this model in the way it's designed. So it's incorporating some of these principles in making decisions when you're purchasing healthcare equipment. Justin?
One of the most obvious examples of that was first versions of automatic external defibrillators. It was a complex series of things you had to do. They were big and heavy and stupid. Carlton used to send their design students to us to each student would be given projects. Every year there was a student who wanted to take on making a more friendly AED. So today you have I won't take any credit for having done any of this, but the defibrillator you see today, a public access defibrillator model, is 1, 2, 3 voice operated, very simple thing that's evolved with exactly the same.
Yeah, so it's quite powerful, and it's an example also of healthcare collaborating with industry outside of healthcare to try and come up with some of these solutions. So these design principles, which are really fundamental to how you're sitting in the chair you're sitting in, how your keyboard works, can also be applied to healthcare equipment. And it can actually reduce the chances of us making errors with them, and as a result, enhance patient safety. So the next question is, lots of people have awesome ideas, right? Generating ideas is not the problem in terms of what can we do to help solve patient safety. The next question is, how do you know if it works? So Pat Crossgary and Bob Weir represent actually, I think, 2 camps that are emerging in patient safety right now. It's sort of the pendulum is kind of swinging back and forth, but very much there's a sense of we need to push system thinking, system solutions, which is really important, and that's what I'm going to talk about today. But I also don't want to lose sight of the fact that I think Pat's work is also really important, and that's why we built the M&M model the way we did, to include both cognitive and system issues, because both come into play. And if you are going to focus only on the system and not think about the individual and human performance, then you likely will be missing the boat. But what I want to talk a little bit about is systems issues. So does anyone know what this thing is? Anyone know what that is? It's a pyramid. Has anyone seen it before? Okay. So this is the human factors pyramid of effectiveness. Okay? And what it highlights is that your solution, and so your basic solution to a problem, can be put on a hierarchy of effectiveness based on the chances of actually making an impact on a system-wide level. So you'll notice at the bottom of the pyramid is education and training. And this is considered on the human factors pyramid to be less effective and more human-oriented. And the basic fundamental principle behind this is that the whole notion that if you tell humans to try harder, less likely to impact system-wide level safety, for example. And a lot of this is principles that are applied to aviation as well. Then you have reminders, checklists, and double checks. This is a higher level of effectiveness because you're actually applying some structure that can help mitigate some of the human error that inevitably will occur. And then you have forcing functions. So forcing functions are basically, again, back to sort of equipment design often, where it basically prevents you from making a mistake. So the IV pump that prevents you from putting in, I want to give, 10 milligrams of dilaudid IV push. So forcing functions, and you can use it for computerized systems, I think, prevent you from making an error. So I'm going to propose another way of looking at solutions. And the other way of looking at solutions is thinking about Band-Aids, safety pins, and hammers. So if we think about a characteristic of a Band-Aid, Band-Aid's sticky, right? You put it on, it's pretty easy. It doesn't stick on very well once it gets or with wear and tear, it tends to fall off. It's kind of considered as a temporary solution. A safety pin, well, you can hold two pieces of fabric together better with a safety pin than you could with a Band-Aid or a piece of tape, right? Not as good as sewing it together, and it is a bit subject to wear and tear. It will fall apart. And the purpose of the hammer, the idea of the hammer, is basically tearing something down and building it up again, restructuring, creating something stronger and more resilient. And I just want to make the point that if you look at this hierarchy of effectiveness, you could consider at the bottom of the pyramid a Band-Aid solution, in the middle a safety pin type of solution, and at the top a hammer. And I want to emphasize, though, that Band-Aid solutions are not necessarily bad solutions, right? So education and training is still critically important. We invest a lot of time and energy in it, and it does accomplish a lot of things. But what I want us to think about is that we can't consider education and training as the complete solution. Because if our response to every single problem in terms of healthcare and patient safety is more education and training, then we will fail. The education and training is definitely important, but we have to step back from that and ask ourselves, what is it about how we design a system that is allowing errors to occur? And how can we make it more resilient so that when we make errors, it's less likely to harm the patient? So that's the distinction in terms of the hierarchy of effectiveness. So I'm going to present a few solutions here. I'm going to ask you guys if you think it's a Band-Aid, a safety pin, or a hammer. Okay? So we talked about 5 key areas in system issues for the emergency department. I'm going to focus on 3 right now. I'm going to talk to you about 3 solutions, one dealing with ED crowding, one dealing with transitions in care, and one dealing with team structure. So ED crowding. So there was an article published in the Annals of Emergency Medicine from the Montreal Jewish Journal, actually, and they implemented a multifaceted intervention to see if they could make an impact not only on crowding in their emergency department, but on reducing return emergency department visits. And their intervention was actually fairly complex. So it included assigning an emergency physician coordinator and an inpatient physician coordinator. And their job was to talk to each other, but also the emergency physician coordinator's job was to ensure that physician decisions happened quickly. And the inpatient coordinator's job was to make sure that discharge decisions and bed availability decisions happened quickly. They also implemented a series of policies. Familiar to us, the idea that you have mixed sex rooms so that you're not having an empty bed because it's a male-only room, that you could have men and women in the same room. They also implemented off-service admissions because you are admitted to general surgery doesn't mean you can't be admitted to a medicine ward. They also implemented a recommendation that as soon as consultation happens, then disposition has to be made within an hour of consultation. They implemented a pneumatic tube system as well as a fax system to departments. And what they did was they looked at before and after study, but they also, which was pretty cool, they actually tried to control for some patient confounders. So they looked at age, sex, severity, comorbidities. And they also compared their hospital to other hospitals at the same time and adjusted for seasonality and potential secular trends in terms of what other hospitals were doing to manage crowding as well. They did not find a difference in terms of return to the emergency department within 7 days, and they also broke this down to see if there was an impact on unscheduled visits or visits related to the index visit. They did, however, decrease their ED length of stay from 16 hours to hours. Pretty remarkable impact in terms of the processes of care for their ED crowding, but no difference in terms of outcome. So if you think about a solution, is that a Band-Aid, a safety pin, or a hammer? So hands up for Band-Aid. Safety pin? Hammer? Okay. So I would actually consider this a safety pin solution. I'll tell you why. You could argue that what they did was there was a lot of change in policy, right? And the physician and coordinators did involve a bit of standardization, perhaps in terms of practice as well as some of the policies. But they didn't really include any forcing functions or automation or computerization to that particular solution. Again, doesn't mean it's a bad solution. It's just thinking about, okay, well, if this solution didn't work, how can you enhance that better and move yourself up in terms of the hierarchy? John?
Are they still doing this? And has that changed length of stay?
Right, so in terms of sustainability, I haven't seen publication from the same authors. Interestingly, I just was spending some time with Eddie Lang last week, who was one of the authors. They have brought some of the principles of what they did there at the Jewish General to Calgary, as well as a whole bunch of other crowding measures they've implemented in Calgary, and they've demonstrated some very impressive improvements in their process of care measures for crowding in Calgary. So it's interesting that they were able to translate some of that to other locations. Transitions in care. So Eddie Lang, also from Montreal, published this really interesting study, which I always found a frustrating study because it's one of those examples of something that makes so much sense and why the heck didn't it work? So their idea was, wouldn't it be good if we could enhance our communication with family docs in the community so that if they knew more about what happened to the patients in the emergency department, maybe they'd be less likely to come back to the emergency department. Makes a lot of sense, right? So what they did was they did a cluster randomized controlled trial with over 2,000 patients and 23 family physician practices. And what they did was they randomized the family physician practices to receiving either their usual practice, which was similar to us. They get a carbon copy piece of paper from their ED record, and in that case it was mailed by post to the family physician. Or you got randomized to receiving an email within 48 hours of patient's discharge, which would contain a link to a secure website which would allow you to access the ED visit, lab results, DI investigations, consultations, etc. And then what they did was they basically surveyed the family physician to say, like, how do you find this? Do you like this? Is it more legible? Is it easier? Is it making your life easier? And they also measured some interesting outcomes, not only return to the emergency department, but also was there less duplication in ordering of tests? Was there less duplication in consultation of services? And what they found was really interesting. And what they found was that there was no change in their 14-day return to the emergency department visits. There was no change in duplication of ordering diagnostics. And for some reason, there was an increase in duplication of consultations in the web-based format. So the next question is like, why? Why would this not have worked? Some of the limitations and the challenges were that they had to get the family physicians on side with wanting to participate, right? So they approached 43 family physician groups, and only half of them agreed to participate. But then you would sort of think, well, the people who agree to participate are probably self-selecting. They're more likely to embrace the solution, right? But interestingly, they asked them, how confident are you in computer skills and how computer savvy do you feel? And about 50% of them said, I'm okay with computers. So then you wonder, too, if like their willingness to embrace that solution may have been limited about how much they were using that in practice. The other limitation, which was kind of interesting, is that they actually approached 4,000 patients to participate in the study. And about 20% were excluded for other reasons, and 30% said, no, I don't want to participate in this, which is also kind of bizarre, right? I don't know why, as a patient, you wouldn't want to enhance your communication with your family doctor, but that was kind of interesting. So I think, you could say there's some limitations in terms of this data and its ineffectiveness, but it's an interesting example of the trial itself was really well designed, and it just didn't manage to show a difference in outcome.
And a copy of the chart is faxed to the family doctor. It's listed on the chart. So it's done by medical records after the fact.
So there is a backup to that system. I think part of the challenge to our system, right, is that A, it assumes that you can read the handwriting. B, it assumes you can read the carbon copy. C, it assumes the family doctor gets it, and then they read it. So there's a whole bunch of components to that system that are problematic, right? So intuitively, it would make sense that the email web-based thing should work. Kathy, did you have a comment? Right. So, like, again, we're talking about information gaps earlier, major information gaps here, but it's just interesting, too, there are other outcomes of ordering diagnostics and consultations, which, again, implies a lack of information. If you don't have information, then you're going to order, the same test because you're not sure if they had it or if they did what the result was, or you're going to consult a service if you don't know if they were consulted or not. So interestingly, when I talked to Eddie about this, and I was like, so what are you doing in Calgary now? He's like, yeah, we're just giving out the carbon copy of the thing. And I was like, oh, that's just so, disheartening. So is that a Band-Aid, a safety pin, or a hammer? Think it was a Band-Aid? James? Band-Aid? Hands up for Band-Aid? Hands up for safety pin? Hands up for hammer? I think this is a hammer. I'll tell you why. This is an example of automation and computerization. This is an example of designing a system where you're not relying on humans to write legibly, to give the piece of paper to people, to mail it, to deliver the mail, right? In the computerized system, the whole point of it is to take away that equation so you don't have to worry about reading human handwriting. You don't have to worry about, like, physical delivery. This is an example of system redesign. This is supposed to be like one of the best types of solutions, is this type of solution. And again, I don't think the solution is bad necessarily. It didn't work in this trial, and it'd be really, but it was a very great, well-conducted trial. But it'd be really interesting, I think even now, as more family doctors have EHR, to see whether or not it would be more embraced now. So transitions in care. Telephone follow-up. This is a really cool study that ever since I read about it, it was conducted in Taiwan. It's always stuck in my head as like this really cool to some of the challenges we have. So basically what they did, and they have a large tertiary care academic center in Taiwan, and they recognize that we have a lot of patients coming back to our emergency department, and how can we reduce these return visits? And so what they did is say, well, who are the patients who really get into trouble? Let's make a list of who we think the most at-risk patients are. So they made the list of who they thought their at-risk patients are, and said, we're going to implement a telephone follow-up. So we're going to call all these patients within 48 hours to see how they're doing. And if we identify they're having a problem, we'll either ask them to come back to our emergency department or see their primary care provider or what have you. That wasn't all they did. The second thing they did was they fed back to each individual emergency physician the outcomes of their patients. So if your patient came back, you would be notified. There'd be like a note in your box saying, hey, FYI, that patient came back. This was the outcome. And thirdly, they held patient safety rounds every month where they basically said, okay, these are the patients who returned this month. These are the themes. We're having an issue with, let's say, abdo pains and missing GI bleeds. How can we overcome that? And what they found was they were able to reduce their 72-hour return to the emergency department by 5%. But remarkably, they were also able to reduce their adverse events from 4% to 1%. It was a small trial. Again, it's in Taiwan, so different system than ours, but really interesting approach in terms of trying to mitigate some of the harm that we do to patients. And I'm going to touch on telephone follow-up again in a couple minutes. So, Band-Aid, safety pin, or hammer? How many would say Band-Aid? Safety pin? Hammer? Okay. I'll call it a hammer, and I'll tell you why. This is an example of, again, a bit of automation and a bit of standardization as well. So the fact that every single patient in that group got a phone call is an automatic process, right? So they built that into a system. They built a new system where they basically said, okay, we're going to make sure every one of these patients get a phone call. And they also said, you know, we're going to do a bit of education and training. So certainly there was some Band-Aid component to their solutions as well. And there was also a bit of attempts at standardization by providing feedback in terms of outcomes and getting people aligned in terms of solutions to certain outcomes. All right, last one is team communication. So in aviation, there's a program called Crew Resource Management. How you have heard of that? Yeah, so CRM, right? So Crew Resource Management, the whole principle behind it is that for a long time in aviation, they would teach all the technical skills, right? So that you would be proficient as a pilot and a co-pilot in terms of your technical skills. And then we're doing all these incident analysis of all these plane crashes. They were realizing that the theme of communication was coming out loud and clear. So they decided, well, we need to actually do some training and education around communication. And so what you get in Crew Resource Management is you get training on leadership, you get training on how to do some error sort of mitigating solutions, and how to actually communicate with each other when you're in a crisis, as well as how to communicate over a hierarchy. So they give you all those tools. There was a group in the States who actually took those CRM principles and made it specific to the emergency department. There's a lot of CRM team-based training for lots of types of healthcare, but this was specifically to the emergency department. And what they did was they did a cluster randomized control trial with 9 teaching and community hospitals, and they randomized them to receiving the team training versus not receiving the team training. We had a group of physician and nurse observers go into their EDs and observe 50 encounters and see how they did in terms of team behaviors and in terms of errors. And so they did this for over 1,000 healthcare personnel. It's pretty impressive. And they found a reduction in clinical errors by 27% and an improvement in team behaviors. They did not follow the outcomes, so we don't know if that translated to actually improved outcomes. But it's an interesting example of actually incorporating CRM principles into team training. Now, some of the limitations of this were that half of the hospitals were Army hospitals. So I'd argue that maybe their uptake might be a little different than the non-Army hospitals. And also half the clinical scenarios were kind of surprising to me. So they said 25 emergent and 25 urgent. But they looked at things like acute MI, abdo pain, and overdose. In my mind, these are not like key team communication types of exercise we do. They covered some trauma, but it wasn't like they went looking at all trauma and all resuscitation. And I suspect, and George can speak to this, is that part of the reason is it's hard to actually go and observe resuscitations because they don't come in on a regular, predictable basis all the time. So was that a Band-Aid, a safety pin, or a hammer? Hands up for Band-Aid. Hands up for safety pin and hammer. All right, so I think it's a Bandaid solution. Again, it doesn't mean it's a bad solution. It's one type of solution. It's training and education. And it's interesting you showed improvement in behaviors. The next question, back to Sean was saying earlier, is that sustainable, and does it impact on outcome? So a next logical question you may have, so that's the Bandaid solution there. So yeah, so basically around the solutions, preliminary work around 3 potential system contributors, and there's more to come on all of these topics. This is really, like I said, exploding right now. There's a lot of literature coming out on this. And for patient safety science is still really new, right? So we're still very much in the descriptive phase, but we now are starting to move into the solution phase, which is making it really exciting. So you might logically ask yourself, okay, so Lisa, you're a patient safety researcher. What are you doing about it? So I'll just highlight a few things that we're doing in our research program on patient safety and emergency medicine that are addressing some of these system issues. So we're performing a couple of studies looking at adverse event analysis. One, which hopefully you've heard about, is our CARE study, which we've just started at the Civic, and that's following patients with cardiovascular complaints for adverse events. We're also doing a patient safety sub-analysis for patients with respiratory distress, the BRAD study, so for the CHF and COPD patients. And we're also collaborating with Amy Plint at CHIO and looking at adverse events amongst kids. We're doing another study, and George is heavily involved with this with a research project of developing a visual situational display to enhance situational awareness for team communication. We're working on M&M rounds improvement, which many of you are familiar with. We've done locally with the Department of Emergency Medicine as well, Division of Trauma. We're now implementing with all departments and divisions at the Ottawa Hospital, and Ed Kwok is leading that. And then for telephone follow-up, we're just finishing a pilot of looking at an interactive voice response system, which is kind of like robocalling, which sounds bad, but actually patients love it, and apparently seems to work really well. And we're looking at doing phone follow-up of discharged high acuity patients, but not a nurse doing everyone, doing a computerized one, a nurse follow-up. So with these projects, we are addressing issues around crowding, because in the CARE study, we're comparing multi-sites, and we're looking at the impact of crowding on adverse events. Transitions in care, same thing with CARE, the CARE study. We're looking at follow-up mechanisms and the difference between sites, if that makes a difference in adverse events. We're looking at team structure and communication with our situational display. We're examining system issues with M&M rounds improvement, as well as cognitive issues that Pat highlighted. And also, we're looking at transitions in care with our interactive voice response system project. So that's just a snapshot of some stuff that we are working on. So in summary, we deliver healthcare within a complex system, right? And system redesign is challenging, and I would say that's actually a paradigm shift in healthcare for us to start thinking about systems rather than individual providers, and also thinking about solutions on a broader level, a bigger level, rather than just thinking about education and training. We need to recognize a hierarchy of solutions, and we can enhance patient safety if we start implementing some of these solutions. Thank you very much.